Welcome to this special edition of Buddhi Insight. The landscape of Alzheimer's disease has changed more in the past 5 years than it had in the preceding 3 decades. We are witnessing a transition from an era in which dementia care focused primarily on diagnosis and symptomatic management to one in which early detection, biomarkers, and disease modifying therapies are beginning to reshape clinical practice. These advances also bring new challenges. How should clinicians interpret emerging evidence, identify appropriate patients, and responsibly integrate new technologies into routine care? It's a privilege to present this webinar hosted jointly by the Asian Society Against Dementia and colleagues across the region and Buddhi Clinic. I had the pleasure of hosting this discussion together with Professor Christopher Chen of Singapore, one of Asia's leading authorities on cognitive neurology and vascular cognitive impairment. We have a distinguished speaker in this webinar, Professor John C. Morris of the Washington University School of Medicine at St. Louis. He is director of the Knight Alzheimer's Disease Research Center. His pioneering work has fundamentally influenced how the world understands Alzheimer's disease, from the earliest preclinical stages through biomarkers, clinical diagnosis, and therapeutic development. His contributions have helped establish many of the concepts that underpin modern dementia research and care. Whether you're a clinician, researcher, trainee, or someone interested in the rapidly evolving science of cognitive disorders, this conversation offers a thoughtful overview of where the field stands today and perhaps more importantly, where it is heading. We hope you enjoy this important discussion. Thank you for joining us for this Buddhi Insight presentation. The challenge before us is therefore shifting from established dementia to identifying disease earlier, selecting appropriate biomarkers, interpreting them wisely, and ensuring that emerging therapies are applied responsibly and equitably. Professor Morris has reminded us that Alzheimer's disease is no longer viewed simply as a disorder recognized after memory fails. Increasingly, it is understood as a biological process that begins years, even decades, before clinical symptoms become apparent. For those of us who are practicing in Asia, these developments carry particular significance. As populations age, our healthcare systems must prepare not only for increasing numbers of people living with cognitive disorders, but also for a future in which precision diagnosis, multidisciplinary care, and preventive strategies become integral to routine clinical practice.
So, welcome to the ASAD webinar. We do this every quarter. This is the Asian Society Against Dementia. And we have someone speak to us about a topic that is of importance. And it's an honor this time to have Professor John Morris from St. Louis talking to us. And we also have with us Professor Christopher Chen, who is the president of the Asian Society Against Dementia. The theme of today's webinar is implementing new Alzheimer diagnostic testing and treatments in clinic. Really a hot topic, also because we now have both the biomarker, the blood biomarker, and the AIDD product in India, both just launched. So I think it's a matter of curiosity, certainly for people in India. About Professor Chen, he's director of the Memory, Aging and Cognition Center at the National University Hospital of Singapore. He's a senior clinician scientist of the National Medical Research Council of Singapore and associate professor at the Yong Loo Lin School of Medicine. Professor Chen trained at Cambridge, Oxford, and the Institute of Neurology, London, and he has built multidisciplinary stroke and dementia research programs with extensive international collaboration across the Asia Pacific. And his interests span neuroimaging, neurochemistry, molecular biology, and the treatment of stroke and dementia. He is the principal investigator of the CHIMES trials, and he serves on various editorial boards, trial steering committees, and data safety monitoring boards. He has over 250 papers and chapters to his credit. Professor Chen is the driving force behind the Asian Society Against Dementia. ASAD is a very dynamic community of people in Southeast and South Asia who meet. We meet once every year, but we also collaborate and do research. So welcome to Professor Morris, welcome Professor Chen, and I'm handing over now to Professor Chen.
Well, thank you so much, Krish. And on behalf of the Asian Society Against Dementia, I very warmly welcome all of you who have joined us tonight for a really wonderful speaker. We're very privileged to have Professor John Morris. Just to elaborate on the Asian Society Against Dementia, we have been a key set of experts across the Asian region over the past 2 decades. And we have, as Krish says, annual meetings to encourage clinical research and implementation of that research throughout Asia. In fact, one of the first meetings was in Chennai, and I'm glad to say that this year, in October, we'll be meeting in Manila, and we'll be very delighted to have you join us there, because I think it will be a very exciting and interesting meeting. But really, the reason why we're here is to listen to Professor John Morris. And Professor Morris really needs no introduction. He's a giant in our field, literally a giant in our field of disease. He has, initiated and led the Knight ADRC at WashU, St. Louis. And I think that he's now passed over these responsibilities to really talented successors, who are still driving forth diagnostics and treatment of Alzheimer's disease. And many of you know that we've made a breakthrough in the last couple of years. And this is due to the achievements of Professor Morris and many others in the field. Professor Morris has published over 950 articles, authored 4 books, received many prestigious awards. And today he's going to be talking to us about how we're going to implement these new diagnostic tests and treatments in the clinic, and describe his experience and insights from WashU. So John, a very warm welcome, and we look forward to hearing from you.
Great. So how do I get my slides back up there? Let's see. There. And all right, are the slides visible?
Yes, definitely.
Yes.
Thank
Great.
you.
Great.
Yes.
Great. Well, thank you so much for the opportunity to present to the Asian Society Against Dementia, and I really appreciate reconnecting with friends and collaborators such as Christopher Chen and Krish. It's great to see everyone. So we're going to discuss today, as Chris Chen indicated, some of the new developments in Alzheimer's disease, implementing new Alzheimer diagnostic testing and treatments with an emphasis about treating real-world patients in the clinic, not just research participants in clinical trials. So here are my disclosures. Our research is funded by the National Institute on Aging. As Chris alluded, I'm trying to relinquish many responsibilities. So I have only one scientific advisory board membership remaining. The Knight Alzheimer's Disease Research Center at Washington University has many, many talented investigators, clinicians, and staff, and those who contributed to the material I'm going to present today are listed here, but I particularly want to thank our fluid biomarker core leader, Suzanne Schindler, our clinical trials unit director, Dr. Joy Snyder, and the leader of our Biostatistics Corps, Kenji Zhang, for their contributions to this presentation. For anyone who will be attending the Alzheimer's Association International Conference next month in London, Dr. Schindler is going to be the plenary speaker on the Monday of the meetings, and it will be a very, very informative presentation. So biomarkers. Biomarkers are required for an accurate Alzheimer's disease diagnosis. We know that it is the clinical assessment of a person with memory problems is not always as accurate as we would like. The Alzheimer's disease, certainly in the general practice community, is often misdiagnosed or undiagnosed, and even in specialty centers, including Alzheimer's disease research centers, the diagnosis is found at autopsy to be inaccurate in 25% of participants. So biomarkers now are increasingly used to determine whether Alzheimer's disease pathology is present, and hence may be the etiology of whatever cognitive impairment is determined. Can't advance for some reason. Let's see. And among the biomarkers, probably the gold standard remains amyloid PET scan. We have a number of radio tracers that, when infused, will cross the blood-brain barrier and bind to amyloid plaques. And then the PET scan will image the amount of radio tracer binding, and hence is a determination of the presence and density of amyloid plaques in the cerebral cortex. Nuclear medicine radiologists will read this as either positive or negative, but also there's a quantitative measure as well, usually now expressed in terms of centiloid, to give an idea of just what the amyloid plaque burden is as determined by this amyloid PET scan. So amyloid PET visualizes the burden and the distribution of amyloid plaques. It is the gold standard. And increasingly in clinical practice, it can be used to determine the success of new disease-modifying anti-amyloid treatments in removing the plaque burden. The difficulty with amyloid PET is it is expensive. It is limited to tertiary, in general, to tertiary medical centers, and so is not very available at all. And it requires highly trained personnel. So it is very limited in its scalability for patients with Alzheimer's disease in general. Another set of biomarkers that is also highly accurate in determining the presence of Alzheimer's pathology is examination of the cerebral spinal fluid. The proteins that are examined in the CSF that indicate Alzheimer's disease include amyloid beta 42, amyloid beta 40, and then total tau and phosphorylated p-tau 181. And there are clearly developed cutoff values for the appropriate ratio that can tell us whether the proteins indicate the presence of Alzheimer's pathology in the brain. The advantages of CSF include the fact that the other assays for non-Alzheimer's conditions can also be performed. But again, scalability is a huge issue. Most individuals have never undergone a lumbar puncture nor wish to. And there are contraindications to lumbar puncture. And again, to obtain CSF to do a lumbar puncture appropriately requires really very highly skilled and trained personnel, and it's expensive to set up these clinics and to perform the lumbar puncture, its procedure. So in the past 5 or so years, we now are shifting to consideration of blood biomarkers. Almost every patient will agree to have blood venipuncture to obtain blood samples, so it's easily accessible and very little resistance to this. And we can again assess the same proteins in the plasma as are assessed in the cerebrospinal fluid, including the A beta isoforms, and now particularly p-tau 217, particularly the percentage of phosphorylated p-tau 217 as analytes. These values then can be determined to be positive for amyloid pathology or negative, depending on their concentrations. And it's much less expensive than the amyloid PET and the lumbar puncture. In the United States, there's still, by the insurance companies who provide medical insurance, there's not always clear reimbursement for obtaining these blood tests, so that sometimes patients have to pay out of pocket. And the tests have only really been evaluated in specialty clinics. That's where the cutoff values are obtained. So we don't know how well they apply to the general population. And nor do we know how comorbid diseases, particularly renal disease, may affect the concentrations. We can't tell from this whether the efficacy of disease-modifying therapies in terms of amyloid clearance is being achieved. And there are many different assays that are used for these blood biomarkers, some of which are much more accurate and consistent than others. So not all AD blood tests are the same. So who should get biomarker testing for Alzheimer's disease? So individuals who have symptomatic disease, not asymptomatic individuals, symptomatic disease for which Alzheimer's disease is considered the potential cause. The biomarker testing then will improve the accuracy of dementia diagnosis and also is critical to determine whether an individual is a candidate for the new Alzheimer's disease-modifying therapies. Many individuals who are not experiencing cognitive symptoms but are concerned because of a family history or other matters wish to have their biomarker testing to determine whether they may harbor amyloid pathology even before there is any cognitive impairment. At this point, it is inappropriate for biomarker testing, blood biomarker testing, or any biomarker testing to be considered in an asymptomatic individual, although there is active research and active clinical trials to determine whether ultimately asymptomatic people may be tested and have the opportunity to try disease-modifying therapies in an attempt to prevent the onset of cognitive impairment. That is not available now. We don't have the results of the clinical trials, so we don't know the appropriateness of trying to test unimpaired individuals. Recent studies have demonstrated that the percent of phosphorylated p-tau 217 is highly accurate in determining the presence of Alzheimer's disease, even though it says p-tau 217. This is a marker of amyloid pathology, and it is very high accuracy in compared to CSF and to amyloid PET. the data are shown here, but it is highly accurate. This percent phosphorylated p-tau217 is in our research and in our clinic the go-to Alzheimer biomarker. So biomarkers can determine whether Alzheimer's disease pathology is present and hence may be a factor or a cause of clinically assessed cognitive impairment. We have 3 biomarker modalities that are available, and the blood tests increasingly are being used in lieu of amyloid PET or CSF. Again, because percent p-tau217 is similar to CSF in its accuracy for the presence of Alzheimer's pathology. 2 of the commercially available plasma tests are now approved in the United States by the Food and Drug Administration, and others are likely to follow soon. We use at Washington University an assay developed by a company named C2N that was co-developed by 2 Knight ADRC investigators, David Holtzman and Randy Bateman. And we've been using that test in our clinic for well over 4 years now. Ultimately, we think blood tests will be the go-to biomarker, and it will allow an accurate diagnosis of patients who have cognitive dysfunction and detect people early in the symptomatic course, so treatment can be initiated as soon as possible. And as I alluded, ultimately it may be that asymptomatic people who are at risk for developing symptomatic Alzheimer's disease may be able to use these biomarkers to detect their suitability for prevention interventions. So I indicated that percent p-tau217 marks amyloid pathology. A newer plasma test for tau pathology is the MTBR tau243 plasma assay, and that also is very accurate and very specific for determination of tau pathology in the brain. And it is the development of tau pathology in the cerebral cortex after amyloid has been present that is associated with the development of symptomatic Alzheimer's disease. These are some of the current clinically available blood-based biomarker tests, plasma test. I mentioned C2N. That's an immunoprecipitation mass spectrometry assay type. It is expensive, but it is very highly accurate. There are other commercial assays listed here, and all of them are trying to assess p-tau217 because that is the most informative assay. So we have amyloid targeting therapies that provide some clinical benefit. 2 in the United States that have been adopted by many cognitive disorders clinics are lecanemab. The sponsoring pharmaceutical company is Eisai. The copyrighted name is Leqembi. It was approved by our Food and Drug Administration in 2023, in July of 2023. And the following July, the second drug donanemab, developed by Eli Lilly and with the copyrighted name of Kisunla, was approved. So 2 drugs now, both of these are monoclonal antibodies directed against deposited amyloid in the form of amyloid plaques. The therapies are administered now primarily intravenously with infusions. ASI has recently released a subcutaneous administration available for lecanemab. And the clinical trials that demonstrated the efficacy of these two drugs lasted 18 months. It's unclear because the trials didn't extend beyond 18 months. In the clinic, do we treat for 18 months and then stop? Or do we treat until the person has demonstrated clearance of their amyloid by an amyloid PET scan? And we are still trying to determine the appropriate length of treatment for these two drugs. But both of them in the clinical trials and in the clinic show that amyloid plaques are removed by the administration of these two monoclonal antibodies. There's appropriate consideration of just whether the removal of amyloid plaques is accompanied by clinical benefit for the patients. The two drugs in clinical trials reduced the rate of progression of Alzheimer symptomatology in the order of 25 to 40% over that 18-month period. I'll talk about what that may mean in just a moment. The drugs are not necessarily benign. First, as I mentioned, they both are administered by infusions, and a fair number of patients get infusion reactions. Usually these can be symptomatically treated without much difficulty. But the major side effect is that the removal of amyloid plaques by these drugs in about 25% or so of patients can produce amyloid-related imaging abnormalities, or ARIA. ARIA is, in our experience, generally asymptomatic. For individuals who have ARIA, the symptoms generally are mild. In the clinical trials, the incidence of death in individuals with or without ARIA, but of treated patients, was the same for lecanemab compared to the placebo group, and low in both of them. In donanemab, the incidence of death was slightly higher for the donanemab-treated individuals. But in generally, these drugs, although ARIA is a consideration, and we'll discuss this, it is not associated with elevated mortality. So here are the data from the two seminal papers reporting the results of the lecanemab and the donanemab trials. In both groups of individuals, the treated patients do decline in terms of their cognitive and functional status, but they decline less slowly than the placebo group. And the question is this clinically meaningful? Is this slowing of dementia progression clinically meaningful? Here's the way we have interpreted this at Washington University. We think that a slowing of 25 to 40%, that amount can improve the life of a affected patient affected with Alzheimer's disease, because it allows them to remain independent in activities of daily living that are important to them. And this could be a variety of activities. Could be meal preparation, it could be ability to manage finances, it could be driving a motor vehicle. And we think that given early in the course of symptomatic Alzheimer's disease, lecanemab extends independence in these instrumental activities of daily living for 10 months. And patients treated with donanemab, again, in early symptomatic Alzheimer's disease, where the tau pathology is low, it maintains independence in these activities by slightly over a year. And both patients and caregivers endorse this prolonged independence as clinically meaningful to them. Certainly the patients want to remain independent. And of course, the longer the patient is independent, the caregiver stress is not a major issue. So yes, these are not powerful clinical benefits, but they are meaningful to patients and to caregivers, and we think justify the use of these drugs. So here are the issues about ARIA. There are two forms of ARIA. ARIA E indicates edema. This is found in, it seems to occur early in the course of treatment with the drugs within the first 3 to 6 months. If an individual has one or two ApoE4 alleles, they are more at risk of developing ARIA. Our practice is to provide serial MRI imaging as patients undergo their treatment with either of these monoclonal antibodies, and we frequently detect ARIA E before individuals develop symptoms. When they have ARIA, we suspend treatment, and the ARIA usually resolves within a matter of weeks. ARIA E can be severe. We have had 3 patients that have required hospitalization, but as I mentioned, about 75% of patients with ARIA E are asymptomatic. We detect it by the serial MRI scans. ARIA H is the other form of ARIA, microhemorrhage or siderosis. It can accumulate over time. Of course, this can occur in Alzheimer's disease, even in individuals who are not exposed to these immunotherapies. ARIA H can co-occur with ARIA E, and again, because of the serial screening with MRI scans, we can detect it, and it's usually asymptomatic. The sequences used to detect ARIA are important. ARIA E is best seen on flare sequences. ARIA H is seen in the clinical trials with GRE or T2 star sequences. We find that SWI is much more sensitive, so that's what we use in our clinic. It is tremendously important to have experienced neuroradiologists make the interpretation. It's often difficult to pick up subtle findings that indicate ARIA E or ARIA H, but we have forged such a relationship with our neuroradiologists and meet monthly with them in our to look at the MRI findings in our treated clinic patients. So rates of symptomatic ARIA E. Here are the data from the clinical trials. Again, when one has one or more ApoE4 alleles, the rate seems to increase, particularly for those who are homozygous for ApoE4. The Eli Lilly company has tried to propose a modified titration, different from what they used in their clinical trial, wherein the initiation of the donanemab therapy is at a lower dose than was used in the clinical trial, and then over a period of several weeks is increased to the appropriate amount. And that seems in preliminary studies to reduce the incidence of ARIA. So who should be considered for amyloid immunotherapy? Individuals with early symptomatic Alzheimer's disease. The the Food and Drug Administration approval said mild cognitive impairment due to Alzheimer's or mild AD dementia. They must have evidence of amyloid in the brain as determined by positive biomarkers for Alzheimer's disease. There is debate. The clinical trials used individuals who were largely healthy other than having Alzheimer's disease, but it's uncertain how well non-AD causes, it's uncertain how individuals with comorbid disorders who have Alzheimer's disease may respond to these drugs. And it is also individuals must have, as I mentioned, must have evidence of Alzheimer's disease by biomarkers. We don't treat people who are demented for whom we don't know that the dementia is associated with cerebral amyloidosis. A question comes up in individuals who are treated with anticoagulants. Some of the recommendations should suggest that such individuals should not be administered these drugs because of perhaps increased risk of ARIA-H, the hemorrhage. We at Washington University have considered individuals who are on antiplatelet drugs or on coagulants as on a case-by-case basis, and we have some who are being treated, and so it's a small number, but so far have not had, in those individuals have not had difficulty. What about ApoE4 homozygotes? Again, recommendations often suggest that people who are homozygous for the E4 allele, because of their increased risk of ARIA, should not be treated. Again, we take this under consideration in our clinic and have had a few individuals who are E4 positive and treat them, but their risk of ARIA clearly is increased. So appropriate use recommendations for lecanemab say that people who are having anticoagulants should not receive lecanemab. And this is the same for donanemab. As I say, in the clinic, we judiciously allow some individuals on anticoagulants to be treated and have not yet had difficulty. So I've mentioned our clinic on several occasions here. What is our operation like not for our research participants, not for our clinical trial participants, but for our patients? We have something called the Memory Diagnostic Center, which is our outpatient clinic where we assess and manage people with memory disorders. The Memory Diagnostic Center has about 3,500 outpatient visits a year. We have 12 physicians, all but one is a neurologist, the other is a geriatrician, and we have 4 advanced practice providers, nurse practitioners, and a physician assistant. And then we're supported by nurses, psychometrists, and medical assistants. Perhaps unusual that in our clinic, all of our patients are evaluated with our clinical dementia rating. This does take more time than is often available in many clinics, but we think it's important to have a clinical CDR at the initial assessment and then at all subsequent assessments. So we have the opportunity then to use in our clinic population the CDR sum box to track dementia progression. So we began administering lecanemab the month after it was approved, so in August of 2023. And now here this month, we have a total of 503 patients who have had at least one dose of lecanemab and 146 patients who have had at least one dose of donanemab. We have the appropriate patients determined and followed and integrated into our clinic standard of care. And as I've alluded, those who are ApoE4 homozygotes and those who are on anticoagulants or antiplatelet drugs are not automatically excluded from treatment. We published our initial experience with lecanemab last year in a publication from in JAMA Neurology that indicated that it is feasible and safe to initiate these therapies in a real-world clinic sample. But our experience is the earlier in the course of symptomatic Alzheimer's disease that treatment is initiated, the less likelihood of ARIA. Individuals who are CDR1 are much more likely, global CDR1 are much more likely to have ARIA than those who are CDR 0.5. I'll give just a few case studies here to illustrate our approach. Here's a fairly young individual, a college professor, has sleep apnea, hypertension, and depression, and came to the Memory Diagnostic Center, wherein his wife said that he had a 1 to 2 year history of increasing repetition of questions and forgetfulness, and yet he was very mild, still employed, and still nominally independent in all of his usual activities. He scored 25 out of 30 possible points on the mini mental state exam at his initial assessment. He could recall none of the 3 items in the mini mental state. And his workup was, initial workup was largely unremarkable, except he had cerebral atrophy, but no microhemorrhages or siderosis. So here we sent him for a Procivity AD2 plasma test. The Procivity AD2 test is a trademark assay from that C2N company that I mentioned that we utilize here at Washington University. And his amyloid probability score, APS2, was 68, wherein we think that individuals who have a score of 68 are likely to be consistent with Alzheimer's disease with positive scores 46 and above, 48 and above. But it wasn't clearly positive. The amyloid probability score is made up of both the amyloid beta 42 to 40 ratio. His ratio was right at the borderline for being positive for Alzheimer's pathology, but his percent p-tau 217 was positive. So we accepted this person as having plasma biomarker evidence for Alzheimer's pathology. Then he had an amyloid PET scan because of the tests were somewhat borderline, and he had absent cortical white matter contrast in the cerebral cortex, and he had an elevated, notably elevated centiloid level indicating amyloid plaques in the brain. So he had a positive amyloid PET study, and we then began treatment for this individual. He did have one ApoE4 allele, and he is on one of the drugs and is doing well. Here's another individual, also a young individual, 52-year-old woman. She had a 4-year history of slowly progressive amnestic difficulties. They seemed to develop at the time she lost several of her family members to terminal illnesses. And people originally attributed her cognitive difficulties to grieving depression over their deaths. But she was employed, and increasingly her colleagues at work were concerned that she wasn't performing her function as well as she had in the past year. By the time she came to the Memory Diagnostic Center, she had retired because of decreased job performance. She had no family history of dementia. She was taking no prescription medications. She had seen a general neurologist before coming to the Memory Diagnostic Center, and she had an elevated p-tau 217 by the Fuji-Ribio assay. The neurologist referred her to our clinic, the Memory Diagnostic Center, but the wait time at the time she was referred for a new patient appointment was 10 months. So this is her Memory Diagnostic Center evaluation. She was forgetful. She needed assistance with activities of daily living. She was continuing to drive, no abnormalities on the neurologic examination, but her mini mental state score was 16. Routine laboratory values unremarkable. She had generalized atrophy and ventriculomegaly on the brain MRI scan. So this individual represents a dilemma. She had mild to moderate early onset Alzheimer's disease, only 52 years at time of initiation of the symptoms, but we determined she was ineligible for amyloid targeting treatment because of dementia severity, mini mental state score of 16. And in part, that may be because it took so long for her to get her new patient appointment in our clinic. And this is a concern that we and other centers and other clinics are concerned about. There aren't enough memory disorders specialists to promptly evaluate all individuals who may be candidates or may be potential candidates for treatment with these drugs. So this is something that we're at our own clinic trying to find ways to expedite individuals and get them a new patient appointment quickly if they do seem to be candidates for the amyloid treatment therapies, but we haven't successfully implemented that as of yet. So this is a concern about the use of these drugs, is identifying people in the earliest symptomatic phase and getting them linked promptly to a memory disorders clinic so they can initiate therapy. So our experience, fusion reactions do occur, but they can be appropriately treated. Our ARIA rate of 23% was similar to that of the clinical trial. 74% of our ARIA cases were asymptomatic, and 76% of the patients who developed ARIA, either symptomatic or asymptomatic, after the treatment was held for a while until the ARIA resolved, then 3/4 of individuals resumed treatment without additional development of ARIA again. So symptomatic individuals, those who are CDR1, so more progressed in their dementia severity, have a higher rate of occurrence of ARIA than those who are CDR 0.5. I'm showing here a symptomatic ARIA, not overall rates of ARIA, but symptomatic ARIA was high in individuals who were CDR1 and very low in people who were CDR 0.5. We have not experienced in our over 600 treated patients, any ARIA-related deaths. So our bottom line is we can integrate amyloid immunotherapy into our outpatient memory disorders clinic. The question is our capacity to see patients and to see them quickly. These are our four advanced practice nurses and one medical assistant who run our advanced therapy clinic. And we have a nurse manager who is in charge, and we are developing ways in which primary care physicians can refer early symptomatic patients quickly to our memory diagnostic center. All right, so we know from the clinical trials that there is treated patients with either lecanemab or donanemab have a slowed clinical progression of their dementia by 25 to 40%, and we believe that that is clinically meaningful. What about in the real world? Is there also clinically evident benefit to treatment? So there are challenges in comparing a real-world clinical experience to the trial populations who are very carefully and rigorously followed. First, what is our placebo group? We have people treated with lecanemab in our clinic, but how are we going to determine if they benefit from individuals who are non-treated? And then we have to examine our memory diagnostics center patients who have clear biomarker positivity, that is, they have Alzheimer's disease and are followed longitudinally but are untreated. So it's not an ideal placebo group, but we have sufficient numbers to evaluate that. And we decided to try to match our treated MDC patients with our untreated MDC patients one-to-one based upon the CDR sum box score at their time of index assessment. The index assessment for lecanemab treatment was their last CDR sum box score before they received an infusion. And for non-treated MDC patients was an initial CDR sum box score. We tried to have appropriate matching on age, sex, the length of follow-up, and presence of comorbidities. However, by January of this year, we had only 147 lecanemab treated patients who had completed 18 months of treatment, as was done in the clinical trial. And the clinical trial had over 850 patients. So we were concerned that we wouldn't have enough treated patients to demonstrate enough statistical power in this smaller group of treated patients to demonstrate a clinical benefit. But we went ahead and did some analyses anyway. So here is our MDC lecanemab treated individuals who completed 18 months. As I mentioned, we had 147 who completed 18 months of treatment. We matched them with other MDC patients who did not get treatment with lecanemab. And we had pretty good matching of these individuals. And here their CDR sum box score was 2.7 in both cases, and pretty good matching on their comorbidities. For comparison, here's our treated patients compared to the treated patients in the actual clinical trial. And again, we're pretty well matched. Note that in the clinical trial, these individuals, at least as determined by the CDR sum box score, was slightly more progressed in their early symptomatic Alzheimer's disease than our individuals. So we used a linear mixed effects model to look at using longitudinal CDR sum box to determine whether there was treatment efficacy or not, looking at the difference in the slopes based upon change in CDR sum box between our clinic lecanemab treated patients and the untreated groups. And this is what we found. So this is not quite for 18 months, but 16 months, but lecanemab treated individuals in our MDC clinic have some visually a slower rate of progression. They do progress over time in their CDR sum box scores, but slower rate in the lecanemab treated individuals versus our untreated control group. Now, there are lots of caveats. So if we look at individuals who were treated for 18 months, lecanemab treated individuals progressed in their CDR sum box score by 1.01 on average, whereas the non-treated individuals had a higher rate of progression on CDR sum box, 1.27, but this did not reach statistical significance. This was with the total individuals, 0.5 and 1. If we limit the analysis to those who were only CDR 0.5, we find that the rate of progression as determined by CDR sum box in the treated group was 0.95 compared to 1.27 for the non-treated group, and that did reach statistical significance. If we looked at 12 months, because we have more individuals who completed treatment, so we have a greater sample size, again, we find that the individuals who both CDR 0.5 and 1 progressed 1.0.5 compared to 1.32. This barely reaches statistical significance. But again, if we limit it to the very mild individual CDR 0.5, we get a greater positive result. So I just indicate here that the overall rate of ARIA in these individuals was 32%, but only 6% were symptomatic, and most were both mild and asymptomatic. So very preliminary conclusions about the efficacy of lecanemab treatment in our Memory Diagnostic Center clinic. If we look at the entire group that we examined, those individuals, 147 treated for 18 months, did not have a statistically significant benefit compared to untreated patients. But if you look at some subgroups, particularly those who were treated only treated individuals who were CDR 0.5 when they began, and those treated for 12 months, more individuals, so greater statistical power, we did find statistically significant slowing. Now, how to interpret this? Well, if you are dubious about the efficacy of lecanemab, you could correctly say that these p-values are borderline. The analyses were not adjusted for different variables. Our untreated comparison group was not an ideal control group of individuals, and that the CDR sum box difference between treated and non-treated patients is small. All of that is accurate. If you're a proponent of lecanemab, you could say that even with inadequate statistical power, the treatment does appear to be associated with slowing of progression of symptomatic Alzheimer's disease in our, quote, real-world clinic. And there is also suggestion that the longer you treat, the greater the difference from the untreated group appears. So we just need to continue to follow these individuals, have more individuals complete 18 months or greater therapy, and reassess, reanalyze the results. All right, so we have to repeat this study with a larger number of MDC patients who have completed 18 months of therapy. We need to address the question I raised early on: how long do we treat people? if amyloid is cleared with treatment, is there a reason to continue to treat with an anti-amyloid monoclonal antibody? What about the efficacy of the sub-Q administration for lecanemab? And as I pointed out, accessibility remains a concern. There just simply are not enough treatment clinics to handle all the individuals who potentially could be eligible for treatment. And even in I called our clinic a real-world clinic. It is not truly a real-world clinic in the general metropolitan area of St. Louis. Just as one example, the percentage of individuals who identify themselves as Black or African American is 18% of our over 500 individuals treated with lecanemab. 3 are Black and all the rest are white. So this is certainly not something that is available to the general population. It remains very slanted towards individuals who are white and affluent. All right, but we have entered the era of disease-modifying therapies for Alzheimer's disease. They slow progression, but they do not stop the disease. They have side effects, ARIA. But the bottom line is we have learned that the earlier the diagnosis is made and the earlier the therapy is initiated, the better the results. And treated patients with early symptomatic Alzheimer's disease have a lower rate of ARIA. There are many more anti-amyloid treatments that are being evaluated in clinical trials, as well as anti-tau treatments, anti-inflammatory treatments, combination therapies, many more candidate drugs. So we have entered the era of disease-modifying therapies for Alzheimer's disease, but much more to come. We are just at the beginning. So with that, I thank you for your attention and I'm happy to try to address any questions.
Thank you so much, Professor Morris. That was a very clear and extremely interesting exposition of advances in diagnostics, advances in therapeutics, and also how you in the ADRC at St. Louis, sorry, actually not the ADRC, how you in the memory clinics in St. Louis have implemented these treatments and shown that it's feasible and it's safe and it might be as effective as in the clinical trials. I'm sure there'll be a lot of questions from colleagues. So, Krish, can you just remind me how would we get questions? Okay, so that would be on the Q&A. All right.
Yes.
Excellent.
Yes.
Okay.
Yes.
So we have a question from Dr. Shivani Arjun, and he or she, asks, as blood-based biomarkers become integrated into routine clinical practice, how are you going to manage discordant biomarker findings and how to weigh them in the context of treatment selection for anti-amyloid therapies?
Yes, thank you for that question. And it is a clinically relevant question because biomarkers, although, as I indicated, are highly accurate, they are not 100% accurate. And we do have occasionally have discordant findings. Blood-based biomarkers may indicate the absence of amyloid plaque, or they may not be clearly positive. They may fall into that intermediate range where we don't know if they're truly negative or truly positive. So our fallback position, particularly when we are considering initiating anti-amyloid therapy, is to get an amyloid PET scan. So I mentioned that I think the plasma biomarkers ultimately will be the way to go in general practice because they're so much more accessible and acceptable, but the gold standard remains amyloid PET. So when it comes to a decision for treatment, yes or no, this is a candidate, we go with the amyloid PET scan.
So, John, maybe I could follow up on that. In many countries around Asia, unfortunately, access to PET is very limited. Um, not, lack of cyclotrons, lack of PET cameras, etc. So, in these situations, um, would you be happy to use CSF as the gold standard, or shall we just proceed with blood biomarkers?
I think if there's a question about if the initial biomarker modality is a blood biomarker and it is indeterminate or there's some question about it, I would proceed to CSF, particularly if the treatment to treat or not hinges upon the biomarker validity. I would go with the results of the CSF in that situation. And Chris, you're absolutely right about the limited availability of PET, of course, in Asia, but of course, in much of the United States, PET is not available too. So this is a clinically very important question: how to make the appropriate diagnosis. And if the initial blood-based biomarker gives an indeterminate assay, I would get either amyloid PET if it is available or CSF.
So, just to press a little harder, John, if you have a strong suspicion that the patient had Alzheimer's disease, typical history, etc., and the blood biomarker was positive, would you have to confirm it, or would you be happy just to proceed?
No, I'm sorry if I wasn't clear. I would only seek amyloid PET if it were available, or CSF assays if the plasma biomarker was giving an indeterminate result. If it's positive, and we do this in our clinic, we don't require, if the blood biomarker is positive and, as you indicate, we have a very strong clinical suspicion that the cognitive impairment is due to Alzheimer's disease, that for us is sufficient to initiate amyloid immunotherapy.
Thank you so much. And I think that that's, of course, predicated on the fact that you have such a well-validated, very accurate blood biomarker test. I would assume that you wouldn't advise this if you didn't have the same assurance of accuracy, reliability, etc.
Yes, that's another good point. We think I don't want to suggest that C2N is the way to go, because one, it's not available everywhere, two, it's expensive, and three, some of the immunoassays, rather than just those that rely on mass spec, such as C2N, also are pretty good. But we think that the C2N assays for the blood-based biomarkers are those that most highly correlate with amyloid PET or CSF results. Some of the immunoassays used by some companies are really not very good, but some are quite good. But it depends on the assay one utilizes to provide a level of confidence that assay is really giving an accurate result. And I think mass spec is the highest accuracy of all, and that's what C2N uses. But C2N is expensive, and it's not now FDA approved, so it's not reimbursable. So there are limitations to that as well.
Thank you. So I think that we now move from diagnostics to issues about therapeutics. So there are, we all know there are many who still are not clear that the treatments have been established to be effective, or even if they are proven to be effective in clinical trials, it's not clear whether they're clinically meaningful. So Dr. T.S. Gael has asked whether there is data to show that compared to patients who have received the best non-pharmacological behavioral and cognitive interventions, is amyloid-targeted therapy clinically superior to these interventions?
A very good question. And the answer is, has there been a comparison? To my knowledge, no, there has not been. And so one can argue, and I think with some justification, that it might be appropriate to try these do that comparison of non-amyloid targeting therapies with amyloid targeting therapies and determine whether there is a benefit for either group. I don't know that I'm unaware that that has been done, but that certainly is reasonable. These amyloid targeting therapies are expensive. They're very burdensome. I didn't mention, but the lecanemab infusions occur every 2 weeks, the donanemab infusions every 4 weeks, so over 18 months. So it's problematic. And if traditional non-amyloid targeting therapies give the same benefit, then that's important to know.
So I believe that in the clinical trials, patients were allowed to be on standard pharmacological treatments.
Yes.
But I think that whether they had access to non-pharmacological behavioral and cognitive interventions is
Right.
not there.
Right. You are correct.
Right.
And that's a very good question.
Yes. So Dr. Abhiram asks, how would you propose we interpret biomarkers in patients with comorbidity? So I know you mentioned that we have to be careful in people with renal failure, but what about those who have cerebrovascular disease? Is there any utility of and he also asks, is there any utility of anti-amyloid therapies in those who are biomarker positive but have coexistent cerebrovascular disease?
Another great and very clinically relevant question for which I think there are no data. We at the Knight ADRC are initiating a study of a group of individuals who are not the traditional people who come to serve as research participants in our Alzheimer's Center. They are about 70% Black, low income, and high rates of comorbidities, including cardiovascular and cerebrovascular disease. We have just started this study, but the goal is to do exactly what the question is directed toward. Do biomarkers perform the same in a population that is much more generalizable and less healthy than we see in research samples? We don't know the answer to that, but that's clearly a very important study. And so we are aiming to get that initiated.
Thank you, John. So just as a point of information, in Singapore, we have validated p-tau217 and published in Alzheimer's and Dementia earlier last year in a research population which had high levels of concomitant cerebrovascular disease. And I'm glad to say that the cutoff points are almost exactly the same. So it doesn't appear that cerebrovascular disease has important effect. But as you say, I mean, clearly, if you had severe renal problems and concomitant cardiovascular problems, there may be some slight effect on the levels of these biomarkers. But I think the question that Dr. Abhiram brings out is very important in that the clinical trials actually excluded people with severe white matter disease, multiple strokes, multiple microbleeds for a variety of reasons. I guess the main one was to not get into trouble with interpreting ARIA. If you have a lot of white matter disease, you might not be able to detect more ARIA. And of course, we know that microbleeds are a complication of ARIA-H, actually. So these patients were excluded. So actually, Dr. Abraham, perhaps we should really be doing trials on people with concomitant cerebrovascular disease, because it is possible that eliminating their amyloid might have a benefit, but risky.
Absolutely agree. Could not agree more.
Thank you.
May I ask a question, Chris?
Pardon?
Can I ask a question, Chris?
Oh, of course, Krish. Please do. Please do.
Obviously, this involves a fair amount of service organization job. And I was wondering, you have obviously a dedicated team of nurses, and you have a whole team of doctors doing the assessments and deciding whether people can have these treatments or not. Do you also have to arrange the emergency arrangements? So if someone is taking the infusion from your memory clinic and they present with symptomatic ARIA, or indeed in routine screening it's picked up, who handles that? I mean, how does one organize those services?
Chris, thank you for that question. We have coordinated with our teaching hospitals emergency room staff to alert them that we have embarked upon treating individuals with these anti-amyloid immunotherapies, and that a side effect, potentially severe side effect, could be ARIA-H or ARIA-E, and we don't want our participants, our clinic patients who are having symptoms of ARIA that need medical attention come to our emergency department and not be recognized as being treated with these drugs, so that the emergency physician may think they're having a cerebral vascular event and try to treat them for that, which would obviously increase their risk of hemorrhage. So we haven't actually had a case like that yet, but it is a concern. And I just, the only thing I can say is we've tried to disseminate this information to our emergency department, so they call. We have now a calls system for our memory diagnostic center, where one of our physicians always is on call. So if anyone has side effects, they will be calling our physician, who will call the emergency room and mitigate against them having inappropriate therapy for presumed cerebral infarct.
Thank you.
Thank you. Krish, is that what you plan to do?
Well, we've been considering setting up the service, so that's why I asked the service management question, because as you know, in India, care can be quite fragmented. And on the one hand, you'll be giving people these infusions, and on the other hand, an emergency happens and they go somewhere, and there is no way for the people dealing with them in the emergency to know what actually happened or what they are doing to cause this particular presentation. So it is a challenge, and I was wondering how we overcome that particular challenge, because apart from informing families and so on, so I was curious about the emergency arrangements.
Yeah, no, you're absolutely it absolutely is a challenge, and I'm fearful that sometimes we won't have the education of the appropriate emergency physicians to avoid a catastrophe. I'm concerned about that. But I have a question for Krish and for Chris about the use of anti-amyloid immunotherapy in Chennai and in Singapore. Has that begun?
Krish, I believe that India has authorized the use of anti-amyloid antibodies.
Yes, I think we just had donanemab become available recently. So that's the first one that's come to India. And I think there are twin challenges at the moment. We only have the blood biomarker. It's very hard to get CSF biomarkers in India because patients don't like submitting themselves to spinal taps.
Right.
The other challenge we have, we don't have amyloid PET. So that's a challenge. And
Right.
diagnosis is a challenge because by the time people come to us, they are somewhat far gone. So to pick up someone who really is suitable with that sweet spot of CDR 0.5 is not as easy as it sounds in the Indian setting. So I think those are the things that we are grappling with at this point in time. But for us, the availability is very, very new, both of the blood biomarker and of the drug, one of the two drugs. They're both very, very new to us. So the first few months, really.
So, John, in Singapore, we were in the second wave of Asian countries that had approval for both lecanemab and donanemab. So, as you know, actually Japan and China were very early adopters, followed by Korea, Taiwan, ourselves, and Hong Kong. And I think that the challenge in Singapore is mainly that is mainly cost. So blood biomarkers aren't a problem, but many people balk at the thought of an expensive PET scan because the reason why we would go on to a PET scan, and of course CSF is not very popular either, is that the the treatment is not reimbursable by the government. We don't have the advantage that you have with Medicare, and the Japanese have with their system, and that most patients will have to pay either through insurance or actually out of pocket. So it's a significant burden. So very often our patients would prefer to go on to a PET scan, which actually, although expensive, is not very expensive compared to the treatment before they go on. And this overall burden deters a lot of patients. Nevertheless, I think that at least about 100 patients have been treated in Singapore, and I think the results are quite gratifying because, as was shown in the Asian sub-study of Clarity, at least for East Asians and Southeast Asians, the rate of ARIA is actually very much lower than in the main trial, and that seems to persist in real-world experience. So whilst we are cautious, we're not paranoid.
Yeah, that's well, that's great. Great to hear. But I agree that everywhere that accessibility is really a major problem. The people who can afford it are going to get it, and we just don't know how the immunotherapy is going to work in the vast majority of people who are not so affluent that they can afford it.
And of course, we share the same problems as you have, John, in that access time to memory clinics is not 10 months. Thank goodness. I mean, but it still takes time, and many people don't come forward because they don't think the symptoms are important.
Yeah, by the time they develop clear-cut symptoms, it may be too late.
Yes, sadly. Yeah. But the government and our research councils are very keen to do more work on early biomarkers to detect patients at risk or subjects at risk, and to perhaps not just rely on pharmacotherapy, but also maybe lifestyle changes, non-pharmacological treatments to see whether that can make a difference.
Sure.
Since I have two experts in front of me, can I ask you about your opinion about one or two other things that have come up not related to amyloid? The one thing, I mean, not directly related to the the amyloid therapies. The one thing that's being talked about is the precuneous transcranial magnetic stimulation, repetitive transcranial magnetic stimulation that targets the precuneus. And TMS is very widely available in India. And of course, delivering it to a specific location is more a skill and knowledge than anything else. The other thing that has landed in India but is yet to be taken by any hospital, to my knowledge, is transcranial pulse stimulation, which is the ultrasound equivalent of TMS, and there is some information that could be helpful. Any wisdom on those approaches, as opposed to these are modern non-pharmacological therapies, a number of traditional non-pharmacological therapies that we use. I just wondered if you had any opinion on that.
Unfortunately, Krish, I have no experience with either of those. I absolutely advocate for exploring all forms of potential therapy. There, of course, is the traditional approach in our developed Alzheimer's disease research centers in the United States to look for pharmacotherapy, and particularly with a focus on amyloid. I think that's important, but I don't think that by any means is the only potential therapeutic avenue, and non-amyloid, non-tau therapies need to be supported and evaluated for their efficacy. So I don't have any experience with that. I can't comment about it, but I'm a supporter of all such therapies, and you and everyone on this attending here today knows that lifestyle changes in particular are increasingly considered as we get the results from the pointer study and now the finger study. So yes, I'm a broad approach, and a broad-minded approach, I think is needed.
Thanks, Krish. I couldn't agree more with John. I think that we need to explore other possibilities, but I would just add, I think we need to explore these possibilities with rigor. I think that if we don't do that, we are not doing our patients good service, because they don't just need hope, they also need effective, safe treatments.
Perfect. Yeah. I think we might have come to the end of the questions, Chris.
I believe so. Unless there's a last-minute surge. I don't think so. So perhaps I hand back to you, Krish, to go and sort of give some final remarks and thanks.
Oh, just thank you so much, John, for taking time off to do this with us. It's really an honor for ASAD to have you join us and speak to us. And it was a wonderful lecture, which brought, I think, also what was most impressive to me was that you spoke about your experience of doing it. And it was not just data, which I think really matters. And it is good to know that we have these new options emerging, but it still watch the space, and we all need to be careful and cautious in how we implement these new treatments as they come into our armamentarium, especially in countries like India, we're just starting to get these now. Thank you for being with us. Thank you for taking the time. I think it's a great lecture. And this will be available online, and I'll share the link with both of you and everyone else. And I'd like to thank the audience for joining us today in the webinar, everyone at ASAD, and of course the hosts at Buddhi Clinic. Thank you so much, everyone.
Great, my pleasure. Take care, everyone. Bye-bye.
At Buddhi Clinic, our mission has always been to bridge neuroscience, compassionate clinical care, and continuing professional education. Through Buddhi Insight, we hope to bring more conversations such as these to a wider audience, helping clinicians remain informed while encouraging thoughtful discussion on the future of brain health. And we are very grateful to have had this opportunity through the Asian Society of Dementia to have this wonderful lecture by Professor John C. Morris. We thank Professor John C. Morris for sharing his extraordinary expertise, Professor Christopher Chen for his leadership in advancing dementia research across Asia, the Asian Society Against Dementia for fostering international collaboration in this rapidly evolving field. Thank you for watching. We look forward to welcoming you to future editions of Buddhi Insight.